Good morning, everyone. I will present a study on the yield of the evaluation of the genetic variant in the pediatric cardiomyopathy. Let's go to some background. Cardiomyopathy is a genetic cardiac disorder and the most common child heart failure. The genotype status of the patient informs the clinical and genetic screening of the first-degree relatives. If the patient tests positive for the gene mutation, family members are offered cascade testing, and only those with a mutation need a regular echocardiogram to monitor for the cardiomyopathy. If the patient genotype negative or harbors a variant of uncertain significance (BUS), family members still require the echocardiographic follow-up. However, reclassification of the genetic variant can change the family screening recommendation. The objective of this study is systematically re-evaluate the genetic variants in the pediatric cardiomyopathy patient to assess the frequency of the variant reclassification. Clinically, actionable reclassification was defined as upgrade the BUS to pathogenic or downgrade the pathogenic variant to the BUS or benign. Inclusion criteria included unrelated pediatric patient with the primary diagnosis of cardiomyopathy enrolled in the multi-center SickKids Heart Centre biobank and having a pathogenic variant or BUS identified on the clinical genetic testing in Tier 1 cardiomyopathy gene. Exclusion criteria included the secondary cause of the cardiomyopathy. Variants were interrupted, update the information on and applying the ACMG criteria, such as clean gene creation, clean variant classification, population allele frequency, variant deleterious prediction using the in silico tool, de novo inheritance, segregation with the disease, and genotype-phenotype re-evaluation. The baseline characteristics of the 227 patients are as follows. 58.6% were male. The ethnic distribution of the predominantly European, followed by Asian and South Asian. The common subtypes were DCM and HCM. A total of 382 variants were identified in these patients, 110 pathogenic variants, and 272 BUS. And 31.2% harbored only pathogenic variant, 54% harbored only a BUS, 50% harbored both. This is a list of the variant reclassified from the pathogenic to the BUS. Overall, 12 of the 100 pathogenic variants were downgraded to the BUS. In contrast, this is a list of the variants reclassified from the BUS to pathogenic. 37 of 272 BUS variants were upgraded to the pathogenic variant. This is a Sankey diagram, variant level reclassification. At the variant level, the number of the pathogenic variant increased from 110 variants to 130 variants after reclassification, while the number of the BUS decreased from 272 variants to 205 variants, with the 47 variants being reclassified as a benign or likely benign. Clinically relevant variant changes were 49 variants out of the 382 variants. This is a Sankey diagram, patient-level reclassification. At the patient level, the number of the individual harboring the pathogenic variant increased from 105 to 121. Meanwhile, the number of the patients with the BUS decreased from 122 to 106 after reclassification. Therefore, clinically relevant reclassification was observed in 49 of the 227 patients. This is a reason for downgrading pathogenic to likely pathogenic to the BUS. The main reason for downgrading was that allele frequency was higher than expected. The next reason was the variant was not located in the mutational hotspot or critical gene domain. The next is the reason for the upgrading BUS to pathogenic. The main reason for the upgrading BUS was the location of the variant in the mutational hotspot. The next reason was a strong deleteriousness predictions from the in silico tools. Variant reclassification by the year of clinical testing. There was no significant difference in the variant reclassification rate by the year of testing. Additionally, there was no significant difference in the variant reclassification rate by the cardiomyopathy phenotype or by ancestry. This is a summary. 12.8% of the variant were upgraded or downgraded upon the variant reinterpretation. Only 3 variants were reclassified by the clinical testing lab. That resulted in the clinically actionable change in the variant pathogenicity in 21.6% of the patient. 40 patients whose pathogenic variant downgraded will require all previously genotype negative family members to return for ongoing clinical screenings. 35 patients whose BUS upgrades to the pathogenic will require cascade genetic testing to be offered to the family members. Conclusion: 1 in 5 pediatric cardiomyopathy patients experience the clinically relevant changes in the variant pathogenicity on the follow-up. This highlights the importance of serial evaluation of the variant pathogenicity by the clinical teams as well as by clinical genetic testing laboratories. These are acknowledgements. Thank you for your attention.